It's wonderful to be back here. We have three amazing women here. The field of women's health has so much to teach us about longevity science. And unless you've been living under a rock, I think everyone knows that the ovary is a critical driver of healthy living in women. We're going to start with the science. Understanding the science is key to understanding the future and the opportunities that lie ahead for women's health span. We're going to start with a pioneering neurobiologist whose research aims to identify novel markers of aging in women. She is a professor, she is an academic, she's a founder. Until recently, the co-director of the Institute of Healthy Aging in Women at the Buck Institute, but currently on the faculty of UCSF's Department of Cellular and Molecular Biology, amongst other things. She has a long list of awards. She is formidable. She's a friend. Jennifer Garrison.
Oh, thank you. Awesome, thank you. I'm really excited to be here. Thank you to Jordan, to John, to Stephanie, to Julia, to the entire team. I think this is really exciting, and I'm really actually pleased that you're all listening to this, because I think you have the opportunity to take what I tell you right now and what we all talk about here on this panel and transmit it to a much larger audience. So I'm here to tell you, just to set the stage for what we're talking about, and then hopefully by the end of my 8 minutes, you will agree with me that understanding female bodies will actually help everyone live longer and healthier, including men. So stick with me here. So I think it's, you don't have to be a scientist or a doctor to understand that female and male bodies are different. You can see it with your eyes, but that extends further down to the cellular, to the molecular level. And there's lots of diseases that manifest the same between the sexes, some that manifest differently, like heart disease, and some that are only in one or the other, like endometriosis or prostate cancer. But it's pretty clear that we know a lot more about male bodies than about female bodies. And we are not here today to rehash all the things that we can agree on, that societal taboos, systemic sex bias in biomedical research, underfunding for research, and also a lack of funding in women's health companies has led us to this point where the female body is like a puzzle that we have not yet solved. And so, I think most people actually don't understand that at baseline, females have a shorter health span than males. So if you're female and you're lucky enough to live to old age, then you are going to spend a significant period of time at the end of your life in poor health, suffering from one or more age-related disease, about 25% longer than if you were a man. So let that sink in for a second. In America, that means that for most women who live to old age, they will spend about 12 and a half years on average at the end of their lives suffering from one or more age-related disease. So why is that? That was something that really drove me kind of crazy. It's because we have these organs, ovaries, that are aging faster than the rest of the tissues in our bodies. So we call this, we call them the canary in the coal mine for aging. And the fact that that's happening is what's setting up this disparity in health span. It has a profound impact on female health span. But I'm here to tell you that ovaries are not just egg factories. They are for more than baby making, and I beg of you, if you don't remember anything else that I say, please, please, please stop calling them reproductive organs. They are important for more than just fertility. And for menopause. They are sitting at the center of a really complex signaling network, a beautifully complex signaling network, and they are talking to almost every tissue in the female body. So they're talking to your heart, to your bone, to your brain, to your skin. I can go on and on. There's the list. But what they're doing is they're promoting health. We do not understand, with any resolution, what those chemical conversations are. That's the gap in the science. But what we do know is what happens when you take them away or when they're not working properly. And so one way to think about it is that they are promoting health throughout a woman's life. And they are important for health at every age. So if ovaries are not working properly, that uncovers different risks for your health depending on your age. So if you're 10 and you're female and your ovaries aren't working properly, that means that you might have issues going through puberty. If you're 20 and your ovaries aren't working properly, that might uncover risk for things like primary ovarian insufficiency or primary ovarian failure. In your 30s, if your ovaries aren't working properly, that uncovers health risks for things that we're more familiar with, like miscarriage and infertility. And in a woman's 40s, when her ovaries start to fluctuate, in function, that uncovers all of the 135 symptoms that are associated with perimenopause, risk for those symptoms. And the reason that there's so many is because if you believe what I told you about ovaries sitting at the center of this complex network, all of those different conversations can change in different ways when ovarian function starts to fluctuate at perimenopause. And so at and after menopause, it uncovers risk for things like increased risk for cardiovascular disease and a whole host of other things that we'll get to when we're talking on our panel. But the key is that throughout adult life, ovaries are important for immune function, for metabolic function, and really, if they're not working properly, it can change your health risk profile. So we call them the architects of health in female bodies, and they are also the pacemaker for aging. And again, we don't understand how they're working. This is the gap. This is where the science needs to catch up. But what we can say is that the cost of not including female data in our knowledge base, it actually extends beyond adverse effects in women. It's actually, when we miss sex differences, we are missing opportunities for breakthroughs that would impact health in men as well. So just one example out of dozens that I could tell you about if you catch me later, is that male and female immune systems are different. So female immune systems are much better at responding to viruses and dealing with vaccines. And so, if you think about the COVID-19 pandemic, men died at twice the rate of women. We have absolutely no idea why, but differences in immune function, had we understood them better, might have helped us change that stat. And there's a lot of things like that. So it's a compelling shift that we're looking at here. And for every one of you in the room, whether you participate in terms of philanthropy, investment in women's health companies, or whether you personally get involved in some way, you all have the opportunity to help us change this trajectory. These are the statistics. Every $350 million invested in women's health research, that's not very much money, should generate around $14 billion for the economy. Now that's a 40x return on investment, which I think is better than most markets. That's on the research side. On the investment side, we are talking about 4 billion people on the planet that are female. This is a huge market, and I'm not going to go through all the numbers, but we're talking about tens, if not hundreds of billions of dollars in terms of market opportunity. So there's literally no reason not to think about this as a place to get involved. And when we talk about, these puzzles, solving them is really it's a plus for everybody. So we're going to talk on this panel. You're about to hear from two amazing physicians who are going to dive into the clinical aspects of ovarian aging and also some of the more practical things that we can do. But what I would say is that while we're waiting for the science to catch up, there are a lot of things that are available right now in modern medicine that are not being applied to women. And there's a huge opportunity for women to take control of their own healthcare trajectories, and we'll talk about that. But thinking about cardiovascular health, thinking about understanding your normal, approaching menstrual cycles as a superpower that you should leverage instead of something that you have to deal with. Thinking about preventative health. For women's health, female physiology is complex, and we need to actually acknowledge it and treat it that way. And that means that personalized medicine, personalization of approaches like hormone therapy, these are going to become really important as we move forward. So I just want to set the stage for some of the conversations we're going to be having. Hormone therapy for women right now is really underutilized. It's a Band-Aid. It's not perfect, doesn't work for everyone. But what we do know about hormone therapy is that it reduces all-cause mortality if it's started within 10 years of menopause by 30%. So I think we need to turn the conversation around, and certainly it's a conversation between a woman and her doctor about risk and benefit. And it's not perfect and it's not right for everyone, but it should be that we start with hormone therapy and then we discuss whether there are reasons you shouldn't take it. We have 50 years of data to show that estrogen is going to reduce your risk of cardiovascular disease, osteoporosis, cognitive decline, and a whole host of other things. So I'll just end by saying that for centuries now, Female bodies have been underserved, understudied, and underfunded. And I think we're all here to demand better. We can do better. We as a group, you as a group, can help with this directly, and I'm asking you to do that. I think we want to choose knowledge over ignorance. We want to invest in understanding all human bodies, because at the end of the day, women's health is human health. So, thank you.
Thank you, Jennifer. Our next speaker is going to move on into the clinical implications of ovarian biology. She is a professor of reproductive endocrinology at the Northwestern Feynman School of Medicine. She's also a director of the Fertility Preservation Service. And your research is looking to uncover the gateway of preventative health in women. And super excited to hear you talk.
Thank you very much. Transport yourself for a moment to a fertility center at a major academic medical center in Chicago. We meet a 30-year-old woman. She's smart, she's proactive, she's health conscious, she has done everything right. She and her partner have been trying for a year to get pregnant unsuccessfully. We talk about her biology, and she realizes she knows nothing except how not to get pregnant. And we review her lab results. We discuss her AMH level, anti-Mullerian hormone. It's the best marker we have of ovarian reserve, the quantity of eggs remaining. It is not a perfect test, but the best we have. And she learns in that moment that her number is exceptionally low. And not only does this predict a poor response to medications that we use in vitro fertilization, there is a clear correlation between AMH and time to menopause. She is aghast that the first time she is hearing this is in the context of inability to conceive and not years earlier. Because you see, the ovary is a window into systemic health, and we are only looking through it at the time of infertility. But we should be looking so much earlier. Think about all of these earlier opportunities. So here we are meeting the patient at 30 years old. But what about 6 years earlier when she had severe pelvic pain? She was started on a birth control pill to control her pain, but maybe that pain represented endometriosis. Endometriosis, there is a 7 to 9 year diagnostic delay. It's no surprise it wasn't diagnosed immediately, but there is an association with accelerated ovarian aging. What if she will go through menopause early, and what could we have done differently? And what about when she was 10 years old? Her mom went through menopause at the age of 40, but our patient didn't know that because they never had that conversation. And it was only until we had a visit and I said, when did your mom go through menopause? And she texted her mother, and this happens in every single consult, and that's when she found out. And why is this conversation not happening earlier when we know that that relationship between a mom's age of menopause and a daughter's is really clear? And if that same patient had gone through chemotherapy for cancer, had a genetic predisposition to low ovarian reserve, like a BRCA1 mutation, Fragile X premutation, Turner syndrome, these are all opportunities that we could have intervened. And in utero, we know that the majority of egg cells are lost in utero. There are 6 to 7 million egg cells at 20 weeks of gestation. By birth, 1 million remain. By puberty, 300,000 remain. By menopause, 1,000. The vast majority of these follicles serve an endocrine function, not a fertility function, and we are only watching as that decline has already happened, rather than prospectively. And so what I'm really worried about with this patient, she's worried about her fertility. I'm particularly worried about what's going to happen when she completes her family and we then have decades remaining. If she goes through menopause early, will have an earlier risk of cognitive decline, so a significantly greater risk of Alzheimer's and vascular dementia. If she goes through menopause early, every 1 year earlier of menopause is going to correlate to a 3% greater risk of incident cardiovascular disease. Every 1 year earlier of menopause increases her risk of fracture by 2%. And if she goes through menopause before the age of 45, she has a 50 to 100% greater risk of hip fracture with significant morbidity and increased risk of mortality. And all-cause mortality is greater with early menopause. For every 1 year earlier of menopause, there's a 1 year shortening of lifespan. So let's dive into the biology of the ovary to understand what we can be targeting here. So the ovary has all of the egg cells it will have at birth. They sit in little primordial follicles that surround the edge of the ovary. And this is where there's dormant egg cells that are dormant at prophase of meiosis 1. A follicle is activated to become a growing follicle. And once that follicle is activated, it is lost. This activation is critical, and this is the key to maintaining follicles in this dormant pool. And so let's take ourselves to Easter Island for a second. Everyone in this room is very familiar with rapamycin and mTOR, and we know that mTOR activation is associated with age-related diseases, and it's a very attractive target to promote longevity, but it also plays a critical role in the ovary. And mTOR is critically involved in that activation from primordial follicle to primary follicle, and so this is an opportunity to harness that ovary and harness the potential of those follicles. And so we return to our clinical consult room, and we have in front of us our patient. And let's think about the different ways that we can utilize the biology of the ovary to potentially protect the ovary and protect her future health span. So first, the acute consult. I have a young patient in front of me who has a new diagnosis of breast cancer. She will be faced with significantly gonadatoxic chemotherapy that will either render her ovaries completely dysfunctional post-treatment or severely suboptimal, but there's a high risk of ovarian insufficiency after chemotherapy. And the only option that we can offer her right now is we can freeze eggs and we can freeze embryos, and that is certainly only viewing her ovary through the lens of fertility, but we can do nothing to protect her ovaries from the long-term risks and consequences of ovarian insufficiency. So in a mouse model, my question was, can we look at mTOR inhibitors to protect those primordial follicles and maintain follicles in that state to protect ovarian function? In mice, it was absolutely effective. So we administered cyclophosphamide, a very toxic agent to the ovary, alongside mTOR inhibitors, everolimus and INC128, and primordial follicles were protected and fertility was protected. What we didn't expect to find is that even without treatment, and we were just looking at the mTOR inhibitors alone, there was a significantly greater pool of primordial follicles. So these follicles were protected, and potentially this has an implication for ovarian reserve long-term and reproductive longevity and ovarian function long-term. And so what we did was we mated mice at a young age after exposing them to mTOR inhibitors and looked at their reproductive function over the course of many months. And at a very advanced age, saw that the mice that were exposed to these drugs had significantly improved reproductive function, and which of course, when looking at fertility, it's just a proxy for the ovarian function, but improved ovarian function over time. And we are now translating this in other models. I'm partnering with Oregon Primate Center, who have treated mice with rapamycin, or treated rhesus macaques with rapamycin and caloric restriction. We're studying their ovaries. And what we really need to do is, if we are going to translate this to humans, we need to understand how these drugs interface with the ovary in humans. There's a population of patients who take these medications, take sirolimus for lymphangioliomyomatosis. We're studying the ovaries of these women. They are young, they have ovaries, they are on single agent treatment, and evaluating what do these drugs do to these patients' ovarian reserve, and what could this mean for other patients if we were to consider this as an intervention. And in my clinical space, I take care of women who are going through infertility, egg freezing, and in the embryology laboratory, we have access to a tremendous, rich opportunity to study ovaries. And so in young women who are freezing eggs, we can remove the cells from the outside of the egg that would otherwise be discarded and study markers that may be promoting aging. And the same for our older patients who are 44 years old going through IVF, we can study those cells. And in fact, the heat map that you see, it's a representative heat map. The red indicates upregulation of kinases. These are proteins that modify other proteins, and we're seeing this upregulation in these older patients, potentially targets that we can look at that are associated with aging in the ovary, and thus would have implications for the health of the ovary and health span. And then ultimately, if we are going to think about translating this to humans, we need to understand dose, duration, timing. How would this actually work in practice? Would we take care of women at 30 and administer a medication and try to protect their ovaries, not just from a fertility standpoint, but from an ovarian health and longevity standpoint? And my area focuses on follicle activation, but there are so many other targets within the ovary. We focus on the cells surrounding the ovary, and we can focus on the vasculature within the ovary. We know that vascular decline is, of course, a critical part of aging. Systemically, we don't understand what that looks like in the ovary. We have so many opportunities. And we need to harness these opportunities to protect women, because the ovary is so much more than fertility. The ovary is heart, brain, bone, and every other organ system. And so we return to our clinical setting with our patient in front of us. She has completed her family. Hopefully she has been successful with in vitro fertilization or whatever tools we have. And she wants to know, how can she support her ovaries moving forward, we need better biomarkers, we need earlier intervention, and we need to view the ovary as not just a window into systemic health decline, but a therapeutic opportunity to promote health span. Thank you.
Thank you. I'm looking forward to seeing a lot of your work being translated into practice and new drugs and therapeutics and biomarkers for women. Our next and final speaker is going to take us into the menopause, prevention, longevity, and how you can help us live better for longer once we reach perimenopause and menopause. Heather is a board-certified clinician. She set up the menopause clinic at the Brigham Women's. She's on the faculty at Harvard Medical School. Heather she's not quite a doctor influencer, but she's a celebrity of sorts. She doesn't try and sell you supplements, but she shared the stage with Oprah and Drew Barrymore. But her superpower is that she's an educator. She's passionate about educating healthcare professionals and the wider audience about menopause and how we can help women. So educating people to help other women. And I witnessed today seeing one of the members of DOC go up to her and say, "Can you come and teach us in our clinic how to look after women better?" which made me so happy. Heather Hirsch.
Thank you. Thank you, everyone, for inviting me. It's such a privilege to be at this conference. So I never thought I was going to grow up and be a menopause doctor. In fact, that was not really on my radar. I always wanted to take care of women. And after I did my internal medicine residency, I did fellowship at Cleveland Clinic. I was really interested in long-acting contraception. I wanted to help women know more about their bodies, peripartum, postpartum. But when I saw my mentor treat women who came to what we call the mistake on the lake, Cleveland, for all these crazy symptoms that they didn't know what was happening to them. They thought they had dementia. They thought they were never going to sleep again. They lost interest in things like sex and even decorating for the holidays. And when she treated them with menopausal hormone therapy, I thought to myself, what is going on? Because they would come back just like full of life and just reborn. And so I knew that that's what I wanted to dedicate my career to, and that's what I've been doing, and that's what I just love doing, teaching, because I didn't get any education on this when I was in training. So I want to ask you, because this is important, so I need to ask a question, so I need a show of hands. Who here does know this recent study, 70,000 women were in a randomized, double-blind, placebo-controlled study that showed an intervention that increased women's health span by 3.2 years. Who knows that study? Yeah. All right, we're going to talk about the forgotten longevity date. Nobody knows what study I'm referring to. Come on, somebody. All right, the Women's Health Initiative. Yes. Great, okay. So I want to start by talking about the forgotten longevity data. So in the in the 1980s and the 1990s, in fact, the American College of Physicians in 1992 strongly advocated that women use hormone replacement therapy. And most women in menopause, early in menopause, were given Premarin, conjugated equine estrogen. And the clinicians saw that it was increasing their lifespan, reducing heart disease, and reducing fractures. Okay, so then they came up with the randomized control study called the Women's Health Initiative. And the Women's Health Initiative changed the game in a good way, but unfortunately, we're stuck somewhere deep in myths and misconceptions about what the science actually showed. So this study was 70,000 women randomized to placebo or menopausal hormone therapy, and they found that women who took the menopausal hormone therapy lived on average 3.2 years longer. Name one medication that we know of that already does that. They also had less cardiovascular disease, the leading cause of death in women. They lived longer, they had less fractures, and they had amazing quality of life. Now, before we go any further, let me define what's menopausal hormone therapy. We use this blanket statement, but it can mean so many things. So menopausal hormone therapy for most women is an estrogen replacement, either in the form of patch, pill, spray, or gel. FDA approved is what I strongly recommend because it has the safety data to go along with this. And estrogen really was, if I have an ice cream cone theory about hormone therapy where estrogen is the ice cream. It's really the main ingredient. That's what actually helped women have less heart disease, live longer, okay? If you have a uterus and you're taking estrogen, you need to take some progesterone with it. And then some women will add some low-dose transdermal testosterone. Some women will add low-dose vaginal estrogen, but it's very personalized, and that's important because some women may be on just progesterone and testosterone. Some women may be on vaginal estrogen and progesterone. Some women may be on all four. All right, so we have a medication that has improved health span for women in many different organs. And the fact that we are not speaking about this every single day and helping women understand menopausal hormone therapy is absolutely wild to me. It's the reason I get up every single day and do what I do, whether it's teaching students, whether it's seeing patients, and whether it's going on social media, because this information is pure gold. So while I know all the science behind this, and I only have a few seconds for this slide, hormone therapy reduced osteoporotic fractures, of which 1 in 2 women will suffer from, of which more women will have an osteoporotic fracture than heart disease, breast cancer, and strokes combined, costing trillions in healthcare. Women's leading cause of death is cardiovascular disease, and in the women's health study, the women who took hormone therapy also had less cardiovascular incidences, MIs, and lived longer. They had less diabetes. Can you believe that? Women who took menopausal hormone therapy, this is science, this is not opinion, had less progression to the development or diagnosis of diabetes. They also had better brain function and improved their quality of life significantly. So how many women take menopausal hormone therapy knowing that? 2%. The 2024 menopause position statement or menopause guide that came out said about 2%, sometimes you'll hear 5%. Imagine if 80% of women were on hormone therapy. You may say, how many women are good candidates for hormone therapy? I would say the vast majority of women are good candidates for hormone therapy, especially when you're thinking about the fact that menopausal hormone therapy could mean different things for different women. So I want to talk to you about, actually before I get there, let's stay on hormone therapy. So here's a couple of myths that I'm going to debunk in about 40 seconds. All right, so we now use different formulations of FDA-approved hormone therapy than we did in the Women's Health Initiative. So in the Women's Health Initiative, we used conjugated equine estrogen and medroxyprogesterone acetate. Now we use FDA-approved estradiol and typically prometrium. When we use prometrium with an estradiol, we see no increased risk of breast cancer above a woman's baseline. The biggest fear that women still have is that hormone therapy increases breast cancer risk. That's because when the Women's Health Study came out, training became extinct, and physicians and women threw their hormone therapy in the garbage because they said there was a 26% increased risk of breast cancer. That is the big reason why we're here. Why only 2% of women take hormone therapy, not 80%. It's still this fear of breast cancer, and it's the extinction of training. So clinicians have not learned how to prescribe menopausal hormone therapy. So I said that the biggest fear that women have about breast cancer is actually debunked. We know that transdermal estrogen does not increase the risks of clots. We know that women start within 10 years, that's when they get the most benefits, although I believe that all women should be counseled about menopausal hormone therapy. They can start in perimenopause, and there's so many positives here, not to mention the economic increase in women who are feeling well, not missing work, not seeing multiple clinicians, as well as how much we would save in healthcare. So I believe in personalized hormone replacement therapy. What does this mean? Well, I've been doing this for the last 12 years, and I found that not all women are going to need the same formula. It is really hard to protocolize hormone replacement therapy, which makes it hard to scale because it must be individualized. So we also want to think about not only do women need estrogen, progesterone, and maybe a testosterone and maybe vaginal estrogen, but what order do they do that? Something I call hormone stacking, which is really actually my way of thinking about precision medicine. Now I have to do this blindly. I don't have enough data to know what are the genetics or epigenetics of someone who's going to tolerate progesterone or not tolerate progesterone, need a gel versus a patch or the patch won't stick. I don't know yet, but what I know is the patterns that I see. Metabolic monitoring is also really important in this menopause manual, which is that not all women must take hormone therapy. I want to make it clear. There's not one right answer, but all women and all clinicians should know the benefits of hormone therapy. We should be monitoring for their A1Cs, for their lipids, as well as for brain markers, as well as for autoimmune and inflammatory conditions that start alongside menopause. And lifestyle is really important. And we all know lifestyle, so I'm not going to harp here for too long, but women who are in supportive communities also have improved health spans 5 to 7 years longer than women who are not in supportive communities. So I believe you have to scale with personalization, which we're going to use AI to help with. So everything that I've either done, taught, or recognized as a pattern, we've turned into a closed loop LLM to help us be able to scale while also personalizing it. Because when you get it wrong, women do not like that. They've already had periods for a lot of years, endometriosis, chronic pain, infertility, C-sections they didn't want to happen. Then you get their hormone therapy wrong, and the clinician and the women throw it in the garbage. So it has to be personalized, and we have to scale it. Teaching is critical. We have a decade or two of clinicians who have never seen a clinician counsel and prescribe hormone replacement therapy. So this is really important. So what is the future here? I want everyone here to know that menopausal hormone therapy is only used by 2% of women. It is something that 80%, if not more, women are good candidates for. And it is the only thing that has shown to increase health span in women. We have the solution. We have to train clinicians. We have to be able to scale, but we also have to personalize. We have to use artificial intelligence for that. All right, thank you guys.
Right, I'm looking forward to questions from the audience, but we're going to start off. I'd like Jennifer to kick us off, try and tease some. I know Cara had some interesting overlaps, so I'd love to start off by seeing if you have any questions for Cara.
Oh, I have a lot of questions for both of you. I think, well, okay, as a woman, I think I'm very curious, and probably everyone in the audience is. Hopefully the men are curious because they have partners or friends or sisters or mothers or other people in their lives who are female. So what do you tell women right now that they should be doing to preserve ovarian function while we wait for the science to catch up?
So it's a great question, and I think about this all the time because I have 3 daughters, and I want to know how to protect them and their ovaries, and I have patients who ask me this every day. And I think the first thing is there are things that we know. We know that your mom's age of menopause matters and can predict yours, and so having that conversation and understanding that and implications, and I think self-advocacy matters. So digging a little deeper if you have that severe pelvic pain, getting answers. And I do think that there's a role, the biomarkers we have are poor. So AMH is not a great marker. However, it is really the only one we have. And so, I would compel women to at least know that information because, yes, it's, there will be some people who will check your AMH and potentially then try to kind of push you to freeze eggs. And that's certainly not the direction that I think everyone needs to go. But I think if you have that lower number, you need to ask some questions about why. Like, is there some predisposition? Should we check a karyotype? Should we check adrenal antibodies? Is there something going on that is driving that? And then how could we intervene differently? And so when she is 38 and she's starting to have hot flashes, she doesn't get dismissed as, you're too young. Maybe that's an opportunity to intervene, and so she knows that information.
So what is the guidebook? 20s, 30s,
Yes.
40s? Give me like a quick,
Here's
what do we do? 20s, 30s,
I think when you're
40s,
21 and you have
to
your
increase
first,
my health span.
Yes, if you're 21 and you're having your first pap smear, we need to teach doctors to have that conversation about ovaries. So I think it's fair in your 20s to see a reproductive endocrinologist.
What tests do you do?
AMH, antral follicle count, estradiol,
I repeat them
FSH.
every year. What else can I do?
No, and we wouldn't necessarily repeat every year. I mean, I think you get a one-time test. If it's low, I think that's when we intervene and say, why is it low? And then you follow that. I think if you're in your 30s, in the same way that we screen for cervical cancer and we screen for breast cancer, and we're really, really good about screening for certain things, we're not screening for ovarian decline, which is ultimately correlates with cardiovascular disease, which is the #1 killer of women. So why are we not thinking about the ovaries in the same way?
So we use the test that is available now, but it's great. Do we do other things, more hormone tests? Is there
Don't smoke.
That is combination?
Yes. So,
okay, 40s. What do I do to increase my health span? What is the guidebook? What are the tests? Do I do scans? Do I do
we need the
tests?
data. We need data. We need biomarker. We don't have that data. We don't. Now, there's a relationship between diabetes and diminished ovarian reserve, BRCA1 mutations. There are all these kind of isolated findings that will correlate with diminished ovarian reserve. But the problem is we need to connect the dots for patients, and it's not currently happening in that way.
So can I clarify, just for people in the audience? So what you just said is that if you have a BRCA1 mutation, that you are at increased risk of what?
Diminished ovarian reserve. So, this is an opportunity. We have young women who are getting screened because their mom has breast cancer. They find out they have a BRCA1 mutation, and they might, be counseled about prophylactic mastectomy, and maybe at 35, they're sent to see me to talk about IVF with genetic testing of their embryos before they have their prophylactic oophorectomy and have their ovaries removed. That person should have been sent at 22 years old when she had the test done, because we could, at that point, intervene. She has a significantly greater risk of diminished reserve, infertility, diminished health span, all of those things. We have opportunities to intervene earlier.
That comes back to this idea that metabolic health and ovarian function are intricately linked. We don't understand how they're related, but they're clearly very, very intricately linked, and immune function as well.
Yes. And that breast cancer patient should also, who has BRCA1, should also be counseled that she should take hormone therapy after her ovaries are removed if she's going to have a bilateral oophorectomy, because they're going to take those ovaries out. But a lot of women think if they have a BRCA mutation, they can't take hormone therapy, which is a huge myth. Because otherwise,
For the non-scientists in the room, are you saying that I could do a genetic test that could find out if I'm at risk of cancer and infertility and potentially early menopause?
Yes.
And I can do something about it and hence increase my health span?
Yes. And the current model, and for the oncologists in the room, the current model, of course, is that when someone's diagnosed, then this testing is done, and you look for a link, and maybe you do cascade testing to look for affected family members, but the current model is such that you often are only diagnosed with these mutations once you've gotten that disease, and we could prospectively look, and what's interesting is when you, do preconception carrier screening, you're trying to get pregnant, you screen for 200 mutations to see what you could pass on to a child. We're not screening for BRCA, we're not screening for CHEK2, we're not screening for all these mutations that have cancer risks, and we should be.
So in that vein, then, how do you see menopause? What are the questions you have for Heather around the future of menopause and increasing health span?
Yes, so many, but I think that what's fascinating from our training, so you were internal medicine trained, I was OBGYN trained, and as an OBGYN in residency, you get no menopause training. Maybe lectures, maybe it's minuscule. And so it is such a missed opportunity. And so, certainly I think that's part of why we're seeing this gap. People aren't comfortable, but what else do you see as the gaps are, and the patient gaps and why patients aren't getting the care they need?
Yeah, so when the Women's Health Initiative came out in 2002, there became this deeply rooted idea that estrogen is dangerous and harmful. And that idea has persisted despite a plethora of evidence showing how important estrogen is. And so I think what we have to do is actually think about, so that caused a lot of biases. One, clinicians didn't want to touch it anymore. Patients were scared of it. And so training became literally extinct. So we need to retrain our clinicians, and we need to actually start to work through those biases that clinicians ourselves have, because clinicians are human too. We got the same message: estrogen is dangerous and harmful. So how do you do that? So I believe that what I've learned in retraining clinicians, I have this incredible community where I've retrained thousands of clinicians. And what it takes is not only learning how to prescribe menopausal hormone therapy, but a community of like-minded clinicians and healthcare professionals that you can work through some of these biases with. They'll say things in this message boards like, okay, I know it's safe, but someone just tell me to do it. It'll be like, should I prescribe vaginal estrogen 4 times a week instead of 2? And if you know anything about medicine, that's very, very safe. And so it's a lot of working through your old biases yourself around prescribing hormone therapy. And we also have this really interesting, what's happening right now is that lay women, are watching all of this on social media, which is a big part of why we're here. So they're going to clinicians and actually feeling like they know more than their clinicians. And this is a weird situation because you want to be able to trust your doctor. You want to be able to help them. We call this the blind leading the blind. So sometimes the clinicians will kind of blindly start prescribing things, which is better than where we were even 5 to 10 years ago, which was, it was just kryptonite and you couldn't prescribe it, it will kill you. So that retraining of clinicians as well as women in society at large, we all have to be using the same message about hormone therapy, because you could also scroll and find 3 or 10 different clinicians or other healthcare professionals talking differently. So I think it's retraining with a community where we can work through these biases that were created in the early 2000s. It's practicing prescribing hormone therapy, because if you are a physician and you've never prescribed a new medication before, especially one that's kind of deemed scary, you're not just going to start whipping out your prescription pad. You're going to really want people to help you prescribe this medication. So in time. So hopefully also too, we could use AI to be able to help clinicians like type in a complicated case and maybe get some suggestions and resources on how they could help. So training both for clinicians and women is key.
Great, okay. We need time for audience questions. So a quick, concise answer to a question I have for Jennifer. So you're looking into the future. In 20 years, we are where we need to be in women's health. I have so much at my disposal to improve my health span and my daughter's. Diagnostics, biomarkers, great biomarkers. We have novel therapeutics. We have next generation menopause replacement therapy that makes me feel like 25.
Fantastic.
But we also have the investors who invested in these programs with their 40x, and hopefully I do an investment and I'm a billionaire. Like, everyone wins. How did we get there?
Oh, how did we get there? Okay, so 3 things. First, all of you are going to go tell everyone you know what you just learned immediately. That's number 1. Number 2, if you are so blessed, you are going to invest either on the philanthropy side or on the company side. If you need ideas about how to do that,
Experts,
Kara Goldman's
real
lab.
experts.
There are other scientists here. Frida Poli, machine learning, AI, women's health. Lots of companies as well. Happy to talk about that later. I think the most important thing, though, is that if we're really going to do this, and I hope you're all listening because this is important, we got there because we had women in positions of power. At least 50% of the positions of power across every single sector, we need to have females in those leadership positions. And I promise you, if we do that change, we're going to solve this problem.
Great questions, finally. Yes, we have one. Oh, okay, there, and next, yeah.
Okay, great. Thanks. I thought that was really interesting. I'm also working in the space of women's health. One of the things that I found most interesting about the presentations today was the connection between metabolic health and menopause. And I'm just wondering, given the environment where GLPs are becoming much more prevalent and they have a positive impact on blood sugar regulation, have you found in your research, I'm just curious your point of view about GLPs and how they affect women going through perimenopause and menopause?
So do you want to speak to that? I can speak to that. I think that it is absolutely the next question. It makes so much sense in terms of the pathways that are being targeted, in terms of the way that insulin signaling kind of activates the mTOR pathway, which activates follicle growth. Like I absolutely think, and we see that when women with diabetes who have activated insulin signaling, women with severe obesity, there's diminished ovarian reserve. And so I absolutely think that this target will also preserve the primordial follicle pool and decrease AMH. We don't have the data yet, but we will.
Stay tuned.
I read on the way over Eric Toppel's Super Ages, and there is an amazing chapter where he talks about GLP-1s and the potential in metabolic health. And if you're in women's health, you can just see all the potential and the opportunity. So yes, it's really exciting. Read that book, Eric Toppel.
Hello.
Hi.
Hi, so I'm Roma. I'm an entrepreneur who's building in women's longevity, and I'm also an exercise physiologist. We talk a lot about data and we talk about AI, and I think coming from the high performance space, we've obviously seen a really symbiotic and very close relationship between physiologists and clinicians. And I think we're starting to see that in the longevity space. A question to maybe Heather and Kara. I talk to a lot of physicians, and we come to them with AI, and we come to them with the piece of lifestyle and the context around everything that cannot be captured adequately in the appointment, where even in a concierge setting, you see the person for longer, but they have to recall everything that happened in the past few months or weeks. What is the data you would like to see, and how do we get physicians to embrace this space?
Oh yeah, I bet we both have different takes on this. So for me, what would be really important is for women to start logging their symptoms. So last night when I was at dinner, the gentleman I was sitting next to said, "Oh, you must use blood work to decide what you're going to prescribe for hormone therapy?" And I said, "Actually, no. I use symptoms." And so if women can start logging their symptoms, whether it's hot flashes, night sweats, brain fog, or it's anxiety or insomnia, and if they can really decide which symptom bothers them the most, for how long they're going on and what triggers them, we can better start them on menopausal hormone therapy. And then because we have to do menopausal hormone therapy a little bit blind, we don't know exactly yet, based on a woman's genetics or epigenetics, what formulation is going to be best for her. The only way that we can tweak that HRT is to go by her symptoms. And women are busy. They don't want to have menopause at the peak of their careers, when their parents are aging, when their kids are going off to college. It's just not the time for menopause to hit. So it's really hard to recall like what night you didn't sleep, unless it was all of them. And so if they could log their symptoms really closely, what AI could do along with me is actually work to create some predictive model of maybe what needs to be tweaked before we have the kind of data to know exactly what someone is going to do.
Yeah, it's Ricky here, because if the Aura talk earlier, he talked about this and how you could almost use the Aura ring to track symptoms and response to treatment and tweak things. But yes, it's an interesting space.
And I'll add, we're seeing signals so early, so even well before someone is, when we expect perimenopause to happen, cycle length gets shorter. So someone may have a 28-day cycle, and it starts to shrink to 27 days, 26 days, and then it starts lengthening. We see these things so early, and so we could be tracking that.
Yes, agree.
Tiffany,
Hi,
you got a question? Hi.
Tiffany Schlane, Jordan's sister. This was a great panel, and I'm blown away that it's just 2% of women on hormone replacement therapy. I know around 3 years ago, there was that New York Times extensive article that I sent to everybody and my brother about, and that I really felt was like a renaissance in women self-advocating at their, it blows me away how many doctors I see that still will not, and I have to pay MIDI Health, MIDI Health will give HRT very inexpensively on top of, what I'm paying. So is that 2% today, or was it 0 before that New York Times article came out?
Yeah, okay, so let me tell you what I know, and all I know is what I know. So in the, we talked about how in the early 1990s, like 65% of women were on hormone therapy. And this is actually where the discrepancy lies, if you want to come to my table talk and ask more, is that when they were doing prospective studies, women were taking HRT right around after menopause, and the timing at which you start really matters, and they were doing well. But then when you randomized, you had women who are older. So 65% of women, let's say, give or take a little bit, were on hormone therapy. It was the ACP's guidelines who put women on estrogen after menopause, and they were doing fantastic. The WHI comes out, and literally that number plummets to about 2%. Who are the 2% that stayed on it? The women who thought, this is bullshit, I'm gonna stay on it anyways. And number 2, the physicians' wives who read the study. Because when you read the study, you actually do see how safe MHT is. So those are the women who stayed on it, okay? So then what happened? SSRI prescriptions shot through the roof. Everyone was prescribed SSRIs instead of MHT. Antidepressants, yes. And so you would think, well, wait, we had this renaissance around 2002, 2003, when the New York Times writes this incredible article. It didn't move very much. Now, in my view, because I think everyone's on hormone therapy, and I think everyone knows how safe it is, of course I know that that's not true, but I also think that has to be more. And I've read different reports. It's probably a hard number to actually get. There's probably women who are on unregulated, compounded, non-FDA prescribed pellets and et cetera that we do not know about, so we may not be accounting for all the women who are actually taking some form of hormone therapy. But isn't it crazy to think, wait, you're telling me we're just where we are when the WHI ended?
Great discussion. Thank you guys for bringing a really important topic for our audience, a mixed audience. I think there are more men than women here. I'm Reena Bhargava. I'm an internist, and I'm building BioTrax AI, a platform for physicians to practice longevity medicine, democratize the care. I think what we need to do is, and I do remember when Women's Health Initiative came out, and one fine day it was, oh my gosh, what were we doing to our women patients? right until then, we thought we were doing great. We were protecting their hearts and everything else. But I think we need to translate this down to real numbers. Number needed to treat, number needed to harm. And that's the kind of medical statistics that really connect with our patients. And then if you say, you know, and I don't know the numbers for this, for each one of those factors, dementia, cardiovascular risk, menopausal symptoms, all of those, that is so translatable. And then essentially at the lay person's level, in community medicine, we can make a change because this has been dragging on long enough and there is no good reason. We don't need New York Times to give us the facts. We really need to chase this and make a difference. Thanks so much.
I agree. I'll tell you one small statistic, because that was a point in and of itself, is that when the WHI came out and they said there was a 26% increased risk of invasive breast cancer, that would freak out any woman. They're like, 1 in 4? Okay, well, of course I'm not going to take hormone therapy. Estrogen is dangerous and harmful. That was the relative risk. So what you're talking about is turning that into absolute risk. So if we actually took a little infograph and we actually kind of put the people who were diagnosed, they actually lived longer than the women who were on placebo and were diagnosed with breast cancer. That's a whole other story. But it was 2 to 4 women out of 1,000 over 5 years on Prem-Pro. The women who took estrogen only had a statistically significant reduction in breast cancer. If we had an infograph on that, it would help tremendously.
That's the most important thing.
Yeah.
All the drugs that were used in the WHI study, we don't use those anymore.
Right.
So it's irrelevant. That's all you need to know. It's irrelevant.
We have 5 minutes. Last question, perhaps.
Perfect, thanks. Hi, I'm Frida, doing an AI and Women's Health Initiative at MIT. Nice to meet everyone. It's a two-part thing. One is who on stage is thinking about the link between PCOS and natural age of menopause, because again, genetically and otherwise, it's pretty strong. And then Kara, you should also know that a recent study came out showing that being a twin or a multiple compared to being a singleton is as bad as smoking for age of natural menopause. So think about that in terms of, you know, the number of people that unfortunately their mother's age of natural menopause may not be indicative. So.
Yeah. Absolutely, yes. And to that point, there are also other ethnic groups where we see earlier age of menopause, and so like this needs to be personalized. You know, patients need to know that they are, that there are unique attributes about them that need to be kind of identified and teased out to personalize their risk, and that's not currently happening. In terms of PCOS, absolutely. I mean, so we see a higher AMH level, and so women with PCOS often they respond very well to medications. They get a lot of eggs and embryos. If they're going through IVF, they have poor quality eggs and embryos, but they do have prolonged endocrine function because they have this really, significantly greater pool of primordial follicles, and so they are actively a group that I'm studying as well because they are so different than the other population with a normal ovarian reserve at the same age.
We have 3 minutes. Any men want to ask any questions? Jordan? Come on, one man. One.
Come on, someone.
Just one. Yes.
I'm going through a process with a very strong-willed 41-year-old Sevillana, a Spanish woman from...
Yes. Oh.
And we're going through this IVF process, and I'm going through it in Madrid, and I'm learning about the international regulations around moving eggs, all that stuff. And I'm curious, where's the best venue for research to be happening? And is it the United States? Because I agree with your comments on NNT. It's going to be patient-funded, and I'm pretty motivated to get it right.
Yeah, absolutely. So you're right, you cannot move eggs or embryos across international lines. And so I think if you're looking at, where there's going to be, where you could kind of do really powerful research with a lot of collaborations amongst a lot of different groups, I think the US probably, there's legislation in other countries that make it challenging. So in Italy, for example, you can't freeze a large number of fertilized embryos. There's, I think, we're staying away from politics, but I think that right now we are okay in most states in terms of what it means to create an embryo and freeze an embryo. There are concerns about personhood bills, and so we could talk offline about that. But I think right now there's so much work being done in the US. The problem is it's just the funding situation.
And just as you mentioned Madrid, Spain is the biggest IVF market because there were, the restrictions on IVF are low. It's a huge research center. Yes. Most of you would have heard of Carlos Simon, who sold iGenomics for $1 billion. So, I mean, they have no restrictions. They have a huge number of clinics compared to the US. And it's where I'd go if I wanted to do IVF, certainly. No offense. I think that's it. Thank you.